Thanks so much, Dr. Chair, for that introduction. Yeah, my name is Waseem. I'm a C2 from Calgary. I've been here for a couple of weeks so far. It's been nice to see you all around. I wanted to talk a little bit today about a case that I had seen in my heart failure clinic in Calgary, and I thought it would be interesting to review the echo of that case and go through some evidence relating to echo assessment of amyloid as well. So here are my objectives. I wanted to start by very briefly reviewing the pathophysiology and epidemiology of cardiac amyloid, just so we have a base to discuss the echo. I wanted to then introduce a case of cardiac amyloid on echo and review basic echo principles relating to that case. I wanted to discuss principles of differentiating cardiac amyloid from other infiltrative heart diseases, and specifically other causes of myocardial wall thickening. Then finally discuss emerging concepts in the evaluation of cardiac amyloid by echo. So I wanted to give a vignette of this patient that I had taken care of. He was a 72-year-old man who had been seeing his family physician for progressive leg swelling. He had NYHA class 2 symptoms. In addition to this, he also examined to be volume overloaded. He had no murmurs, no signs of severe aortic stenosis, but was clearly in heart failure when we had seen him. He had 3+ peripheral edema all the way up to his knees. He was hypertensive, 154/101, satting low normal and room air, but otherwise stable and warm to the touch. His medical history was significant for carpal tunnel. He had left and right carpal tunnel release procedures quite a years back in 2011 and 2012. He had some dyslipidemia and type 2 diabetes that was fairly well controlled. Medication-wise, he was on rosuvastatin 5, metformin 500 BID, dapagliflozin, and bisoprolol. So going to objective 1 of Echocardiogram, review the types of cardiac amyloid and pathophysiology and epidemiology. This was his electrocardiogram. This was one of the things that had tipped us off that this was more than just bread and butter congestive heart failure. He had low voltages on his electrocardiogram, especially in the limb leads, criteria being less than 5 millimeters. And he also had a pseudo-infarct pattern in his anterior leads with poor R-wave progression concerning for pseudo-infarct. And in one analysis, chart analysis, this was seen in up to 46 to 47% of patients. Histologically speaking, left we have a slice of normal myocardium. You can see that the interstitium is not abnormally expanded. On the right with a Congo red stain, there is a kind of chaotic distribution of amyloid fibril deposition between myocytes that's responsible for the wall thickening, diastolic dysfunction seen in this disease, as well as the pseudoinfarct pattern. There's several subtypes of amyloidosis. Of great importance to us is the transthyretin amyloidosis, as well as the AL light chain amyloidosis. AL light chain occurs essentially in the context of a monoclonal malignancy, AA amyloid in a chronic inflammatory condition, but it very rarely causes cardiac amyloidosis, whereas in AL amyloid, 50 to 70% of cases are known to involve the heart. TTR amyloidosis is probably the overall most common cause that we will see of amyloid, specifically the wild type TTR mutation. TTR is essentially a protein that's responsible for transport within the body, and wild type essentially involves dysfunctional proteins that occur in context of aging. It's not necessarily a pathological mutation that it's occurred, but rather the interaction of the protein with its environment. Whereas in ATTR hereditary amyloid, or this mutated type, there is some discrete mutation that's caused there to be dysfunctional protein and deposition of protein in the heart as well as other tissues. This mutation is quite common in African Americans. There are other mutations of hereditary amyloidosis that occur in other populations, and they often have a more neuropathic presentation. This occurs in Northern European populations as well as in Japanese populations, but not particularly this mutation. In terms of the wild type ATTR, certainly with that type, carpal tunnel is a feature that occurs there, as well as neuropathies in general. I think just overall important to recognize that 25% of hearts over the age of 80 have wild type ATTR amyloid deposits, and that was known since there was autopsy studies in the 1980s. I thought that this was interesting. This was from a JACC state-of-the-art review about the incidence of amyloidosis, or the diagnosis of it. Clearly that there's been a takeoff in the number of cases that have been diagnosed for wild-type amyloidosis particularly, but as well as hereditary amyloidosis in the 21st century. Not necessarily the case that there's been an increase in the disease itself, but rather that we're recognizing it a lot better. And I'll discuss some more of these kind of epidemiological facts on the left, but essentially the disease is under diagnosed, and there's a relatively high prevalence of patients who have it, including 10% of all patients with heart failure with preserved ejection fraction over the age of 60. In the case of a transthyretin amyloidosis, the protein is initially made in the liver, and a series of kind of dysfunctions in the creation of the protein or the modification of the protein results in deposition in different organs that causes the manifestations of that disease. So here I wanted to introduce the case itself. So here's a parasternal long axis from this gentleman who we ordered an echo on due to his symptoms, and it essentially shows in the RVOT that there's good RV systolic function. There's no clear or large anterior pericardial effusion. The aortic valve and the mitral valve both appear somewhat thickened, but open and close well with no clear coaptation gaps. The aortic root and ascending aorta were not dilated, and there was no posterior pericardial effusion noted either. But interestingly, from this point of view, you can see that there's substantial concentric left ventricular hypertrophy. This gentleman was fairly large, so his index mass came out to 131, consistent with moderate concentric hypertrophy given his RWT being around 0.6. There's also a fairly small LV cavity size here, as well as substantial septal and posterior wall hypertrophy, in both cases measuring around 18 to 19 millimeters, or normally that would be less than 11 millimeters in a normal patient. This was the parasternal long axis view with color applied. I'm getting an error there. Can you guys see that at all?
We see a gray screen right now.
Okay. Okay, well, there was no significant MR, just now.
Yeah, but we could see it at a second time.
Yeah, now it works. Thank you.
This is the tricuspid inflow view. So here we see a mild to moderate centrally directed jet of tricuspid regurgitation. There was no quantitation done from this view, but it was felt overall that the tricuspid regurgitation was not within the severe range. There was no flow reversal in the hepatic veins and systole. Parasternal short axis at the base, you can see that there's some hypertrophy at the right ventricle, hypertrbiculations. The aortic valve appears thickened, so does the tricuspid valve. There doesn't appear to be a coaptation gap in the tricuspid. The aortic valve is trileaflet, Again, we apply color to the tricuspid valve. There is moderate tricuspid regurgitation on this view based off of the color depth and how much of the right atrium it occupies. Also considering that the right atrium is substantially dilated in this patient. There is an area of flow convergence seen throughout the anatemic orifice during systole. And again, a PISA was not done for this regurgitant jet, but the orifice itself is not the typical hemispheric shape that would allow for adequate PISA calculation. But the area of flow convergence seen suggests that this is more likely moderate than mild. The CW of the tricuspid regurgitation showed a peak velocity that was around 4.4 meters per second, which corresponded to an RVSP estimate of just around 80 millimeters of mercury within the severe range for pulmonary hypertension. The dense round jet, in this case, supports a moderate severity for the tricuspid regurgitation as well. Mind you, this patient was atrial fibrillation, so ideally you'd want to sample multiple jets. This was the patient's typical 4-chamber view. I think strikingly, this patient has severe biatrial dilation. The left atrial volume index was around 67 ml per meter squared, comfortably within the severe range. The LV systolic function is clearly normal. On this view, it doesn't appear to be any regionality to it. The mitral and tricuspid valves again appear somewhat thickened. There's some thickening of the interatrial septum that's appreciated. The RV looks slightly hypertrophied as well. The ideal view for that would be the subcostal view. The RV function overall came out to preserved on the basis of the TOPSI and the RVS prime and visual assessment, but it was mildly dilated at 4.3 centimeters, which of course fits with this patient's history of severe pulmonary hypertension. In addition, the RV dysfunction and dilation could be seen from intrinsic myocardial disease. At this point, we did not know that this patient had amyloid. This is a zoomed-in view of the right ventricle, again showing preserved systolic function, dilation at the base, 4.3 centimeters, and preserved LV systolic function. Contrast was not given in this case. In this apical 4-chamber view, there is a TR.
Oh no, you can only hear my phone.
I'm sorry?
We did on your phone. Yeah,
Sorry,
please continue.
Okay. On the apical 4-chamber view, you can see there's a medially directed tricuspid regurgitant jet. Similar to those seen previously. The apical 2-chamber view shows no regional wall motion abnormalities in the inferior and anterior walls, left atrial dilation, and preserved systolic function. I think this is where the case gets most interesting. Strain analysis in the apical 4-chamber shows highly abnormal strain at the basal and mid segments, but preserves global longitudinal strain at the apices. On the 2-chamber view, the exact same pattern is observed, highly abnormal strain at the base and normal strain at the apex. And I'll discuss kind of how to interpret strain as well. This is a plot that makes it a little bit easier to kind of combine strain analysis from multiple images. This patient's ejection fraction by the strain software did come out to 52%, so within the low normal range for a male. But clearly at the base, the strain is positive to less negative than it is at the apex, where it is most intensely negative and normal. And this apical straining pattern was suggestive of cardiac amyloid in this particular case. So I'll discuss kind of principles of differentiating cardiac amyloid from other infiltrative heart diseases and causes of wall thickening. Essentially, there's a few features in the literature over the years that have come up as concerning for cardiac amyloidosis. Increased LV and RV wall thickness is one of those significant features. However, as you know, that there's many different causes of a thickened myocardium, and seeing this alone would not be sufficient to make a diagnosis of amyloidosis, given that it is one of the more rare causes of wall thickening. There's a few other contenders for diseases that will cause myocardial thickening. I think chief among them would be hypertensive heart disease, which can also cause wall thickening and usually does in a concentric left ventricular hypertrophy, which is typically the case for amyloid. However, as we'll see, 20 to 25% of amyloid cases also have asymmetric septal hypertrophy and can look quite a bit like a hypertrophic cardiomyopathy patient who has a septal hypertrophy as well. So on its own, LV-RV wall thickness, although it's a very important tip-off to the presence of amyloidosis, is not enough to make that diagnosis. Because of the impact of amyloid fibrils on different parts of the myocardium, not just the muscle, but also the heart valves and the interatrial septum and the atrial walls and myocytes, there can be thickening seen in structures besides just myocardium. So valvular thickening and interatrial septal thickening is very important as well for a clue to amyloidosis. And in terms of predictive power and sensitivity of seeing those features, there wasn't good literature that I came across about how often you should expect to see those. Speckle tracking is what I had just displayed, is essentially a way of looking at myocardial strain. I'll kind of define strain in more detail and look at what the strain patterns are. But speckle tracking strain analysis does become essentially a cornerstone of amyloid diagnosis and suspicion in terms of echo. And just as a caveat, none of these echo features are strong enough to make a complete diagnosis, but rather raise suspicion and advise on additional investigations that might help make that final diagnosis. Number 5, diastolic dysfunction is frequently seen in patients with amyloidosis due to the impact of amyloid fibril deposition on myocardial relaxation. Often E prime will be decreased and E velocities will be increased as you depend more on that mitral inflow, early mitral inflow for filling. A speckled appearance of the myocardium and valves, I thought this one was interesting, and I did want to hear what the echocardiographers had to say about this. Essentially, because my understanding is that this is less important in the era of harmonic imaging, the speckled appearance of the myocardium and valves. But it is one of the things that was reported along in the literature that you can look at the echo of a patient with amyloid and tell from how the myocardial fibrils look that there is an amyloid present. Number 7 is the presence of pericardial/pleural effusions, which occur both as a consequence of pulmonary hypertension as well as due to impact of permeability of those membranes due to amyloid. And finally, the presence of low flow, low gradient aortic stenosis is becoming something that's increasingly recognized as an echo feature of amyloid. So as I mentioned, increased wall thickness is one of the hallmarks of the disease. As you can see in this echocardiogram of this patient, there's both septal and posterior wall thickening that occurs in a concentric manner, clearly above the thresholds for abnormal. This patient had around 18 millimeters of thickening, but in the literature, anything above 11 is typically considered in keeping with amyloidosis. Of important note is that patients who have AL amyloid compared to ATTR amyloid typically do not have the same degree of myocardial wall thickening. Unclear why that might be the case. potentially could be related to the rapidity of the progression of the disease. In AL, the process you can imagine might be more acute in the setting of a malignancy compared to ATTR, where theoretically deposition had been occurring for quite some time, probably decades. One interesting review of biopsy-proven cardiac amyloid and HCM correlated with genotyping had shown that asymmetric septal thickening occurred in 20 to 25% of patients who had a diagnosis of wild-type ATTR. So you can imagine how that would overlap with our hypertrophic cardiomyopathy patients who also have asymmetric septal hypertrophy. In this series of 298 patients who actually had a diagnosis of HCM, on biopsy, 5% of them had amyloid and were genotype positive for hereditary ATTR. So I think it's important to keep the differential diagnosis in mind when we're looking at cases of wall thickening, even if it is concentric. One of the early kind of tip-offs as well as diagnostic parameters in the assessment of amyloid was on tissue Doppler imaging. Here we have a tissue Doppler of the mitral annular plane of the lateral annulus, and with an E prime velocity of 0.04 meters per second, this would be markedly abnormal. Less than 0.10 meters per second would be considered abnormal, so this is quite low. And early decrease in diastolic function is fairly common in amyloid and might be a clue if the diastolic dysfunction is out of keeping to the degree of wall thickening that's observed. It's also of prognostic importance. This is taken from the American College of Cardiology, and patients who have an E prime velocity of greater than 15 have much lower survival, drastically lower survival actually than patients who have preserved filling pressures. So it's important, I think, to point out and comment on that when we can. This patient's mitral inflow velocity, of course, atrial fibrillation is, you can't really comment, but an EA ratio greater than 2 would be consistent with elevated left atrial pressure. But again, none of that would be specific for restrictive cardiomyopathy and much less necessarily so for amyloidosis, but just something to keep in mind when interpreting the echocardiogram. Speckled appearance of the myocardium. Here is an example from a publication that I had seen describing this originally. And the speckled appearance is seen in the interventricular septum in this case, where there's a different degree of echo brightness observed. And my understanding is this is something that is less applicable to modern day echo due to the advent of harmonic imaging. It would be interesting to hear other people's thoughts on that. It's also been described a speckled appearance in hypertrophic cardiomyopathy, glycogen storage diseases like Fabry's disease, as well as in dialysis patients who are receiving, who are in end stage due to amyloid deposition related to dialysis. Here's another example of that speckled looking myocardium. I wanted to spend some time discussing myocardial strain. So strain describes more the deformation of the myocardium in multiple planes. When we talk about strain, there's also three types of strain that are used in echo. The one most commonly applied is longitudinal strain, which I'll show an image of, but essentially strain is describing the change in position from a beginning to an end point, and it's typically described as a percentage. Positive strain describes thickening, negative strain describes shortening, and depending on the plane that we're describing, you can expect there to be either shortening or thickening. Here on the longitudinal plane, normal myocardial motion in systole would involve shortening in the longitudinal plane. And speckle tracking is a technology that's used to determine how much that shortening happens. So even though the myocardium is thickening when we discuss ejection fraction, in the longitudinal plane, there's that shortening motion that's taking place between diastole and systole, which is well shown here. Multiple planes are, it's possible to talk about thickening and shortening in multiple planes. In fact, in the radial plane, typically the myocardium will thicken and lengthen, and in the longitudinal and circumferential plane, the myocardium will shorten. So in the setting of global longitudinal strain, a less negative value would be more abnormal, because that suggests that there's less shortening of the myocardium lengthwise. One of the issues with strain and challenges is that it involves different software and packaging from people who make that strain analysis software, and that might not necessarily be transferable between different centers. So it can make strain analysis numbers difficult to compare center to center. In this example here on the bottom left with the bullseye, the plot that I had shown earlier for our patient is depicted here again, with the strain values at the apex in the middle here, at the mid, and then at the base. And this is a way to kind of assess if there's any pattern to the strain abnormalities, if there are any. That can also be described numerically by looking at the average apical strain and dividing that by the average of the basal and mid strain. There's been kind of different ways to quantify that visual gestalt. I think what's also interesting about global longitudinal strain and EF correlation is that they do correlate very, very well, but GLS is more sensitive to very small changes in LV function, which might explain its helpfulness in patients receiving chemotherapy where we need to catch LV dysfunction fairly early. One of the strengths is that it also doesn't rely on a single point of motion. For example, tissue Doppler imaging looks at often the annular planes in the case of TAPSE and MAPSE. But of course, that has its limitations that become very clear if the patient, say, has mitral annular calcification. Longitudinal strain is something that looks at all aspects of the myocardium, and that speckle tracking technology provides a more holistic overview. There's a strong correlation with EF and GLS. For example, in this meta-analysis of different studies, one of the GLS averages in a study was -8, and this correlated to an LVEF average of 31. Whereas, say, in a study showing an GLS of -15.8, this correlated with an LV of 56%. So they do correlate quite well. But GLS has a better association with all-cause mortality. In the same meta-analysis, changes in LVEF, although it did have correlation with mortality, this was a lot less robust than in patients who had abnormal GLS strain values, where the correlation with all-cause mortality was much better across this meta-analysis that involved almost 6,000 patients. In the setting of amyloidosis, I think these speckle tracking parameters do have strengths. For example, in 172 patients with cardiac amyloid, 80 of them had AL amyloid and 92 of them had ATTR amyloid. Almost 100% of the patients had abnormal radial strain, and 93% of them had abnormal longitudinal strain. 77% of them had abnormal tissue Doppler indices, and only about a third had the low voltage pattern, an LVEF less than 50%, and a restrictive filling pattern. So the speckle tracking does have its advantages. One really important point is that the degree of the pattern of abnormality in patients with cardiac amyloid is very important as well. On the left here, we have a bullseye plot of GLS in an amyloid patient, you can see that at the apex, the GLS is fairly preserved, but at the mid and to basal segments, this becomes highly abnormal. Any GLS below negative 15 to 16% in absolute value would be considered abnormal. So essentially, the less negative, the worse. And here the apex is less abnormal than the other segments. In the right, you have a patient with hypertrophic cardiomyopathy where there's no kind of gradient, and also the GLS is fairly preserved overall, which typically mirrors the ejection fraction in patients who have HCM. The sensitivity and specificity of this pattern was quite good, the 93% sensitivity and 82% specificity in this initial kind of analysis which described this. In addition, the strain in amyloid has both prognostic and diagnostic value. A GLS less negative than 14.81% is predictive of all-cause mortality. And the relative regional strain ratio, which is what I was describing before, of the strain ratio between the apex and the basal segments, is also predictive of death and transplantation. Another thing that's suggestive of amyloidosis and often used on echo is the presence of a pericardial effusion. This is not our patient, but this is a patient with amyloidosis who has a clear posterior pericardial collection here. Though this wouldn't cause any raised intracardial pressure at that degree, there is definitely importance to pointing it out. In an analysis of patients with AL and ATTR amyloid, 143 patients, less than half of them had no effusion. A quarter of them had an isolated pleural effusion, and 17% had an isolated pericardial effusion, and 13% had both of those. And I think the benefit of pointing it out is that it can be a clue to raised pulmonary pressures, but also pleural effusions, particularly in this analysis of patients with AL and ATTR amyloid, had prognostic value for predicting survival. Of course, this is just an observational analysis, but patients who had pleural effusions did worse than people who had no effusions or just pericardial effusions. Whether that's related to pulmonary pressures or other mechanisms is not clear. The association was seen most clearly in people with AL amyloid, which may reflect extent of malignant disease in that condition. I wanted to take some time to also discuss kind of some emerging concepts in cardiac amyloid and its evaluation by echo. So we talked about all these features that can support the presence and absence of cardiac amyloid, the spectral tracking technology, the wall thickening, interatrial and valvular septal thickening. But these are all things that are suggestive but not diagnostic. The apical sparing pattern is probably the best thing that we have on echo to suggest amyloidosis, but it's not perfect either. There was one paper that was published in 2017 that took 100 patients, 40 of them with HCM, 40 of them with cardiac amyloid, and 20 with hypertensive heart disease. And they compared kind of echo parameters between those groups. Between the cardiac amyloid and HCM group, there was a similar degree of septal maximal wall thickness, much more than the hypertensive heart group. Ejection fraction was a touch lower in CA patients compared to HCM and hypertensive patients. And the mass index was also much higher in the cardiac amyloid group. But again, none of these are things that would be diagnostic. And in this study, one other thing to point out is that all these CA patients were biopsy-proven CA patients, of which 2/3 had AL amyloid. But in their analysis of what was most predictive, they described some new novel echo kind of features. And one of them that was most predictive was the EF-SR ratio. This was essentially a ratio of the ejection fraction to the global longitudinal strain, and essentially was born out of an observation that patients with cardiac amyloid had relatively preserved ejection fractions, but very abnormal or much more abnormal than other conditions, global longitudinal strain, which resulted in quite good discriminating ability for this. When looking at the area under the operating curve, the result was 0.95 for this EFSR ratio, much better than 0.85 for GLS, and the 0.7 for ejection fraction and 0.69 for tissue Doppler indices. So I think the ejection fraction strain ratio is an interesting concept that could have some promise, but it really reflects our intuitive assessment of kind of strain and EF and amyloid anyway, which involves kind of abnormal GLS out of proportion to myocardial dysfunction. Another thing that I think is interesting and kind of emerging is the presence of concomitant severe aortic stenosis and cardiac amyloidosis. In this analysis of 151 patients with severe AS by pyrophosphate scans, 24% of patients who had severe AS going for TAVR also had amyloidosis. So 16% of them had cardiac amyloidosis in the senile TAVR population. The mean age was 84 here, and 68% of these people were men. But clearly, you know, that's a very large, almost 1 in 8 patients who have another disease. And I think it's you know, important on echo. These patients with ATTR have worse diastolic function, slightly lower ejection fraction, and thicker walls, but they also don't have an apical sparing pattern on their echoes necessarily. So this paper published in the European Heart Journal shows above how in patients with both severe AS and amyloid, that cherry on top global longitudinal strain pattern is not at all observed. But very interestingly, there was another paper recently published about cardiac amyloid and TAVR patients that showed that following reverse remodeling in patients who have severe aortic stenosis and amyloid, that patients with cardiac amyloid and severe aortic stenosis compared to those who just had severe aortic stenosis did not have the same improvement in LV mass regression, whereas people who just had lone aortic stenosis did. In addition, global longitudinal strain improved in both of the groups, but after TAVR, the patients who had ATTR had another base to apex gradient appear. So even though prior to TAVR that kind of apical sparing pattern was not present, patients who have cardiac amyloid in addition to severe AS did have that gradient emerge after their procedure. I think prognostically it might be helpful as well to recognize the coexistence of these diseases, since at 1 year post-TAVR in this study, the patients with amyloid had worse NYHA class, with 36% of them having class 3 symptoms as opposed to 14% of the lone AS patients. They also had higher troponins and higher NT-proBNPs. And finally, in terms of novel markers, one thing that I've been seeing as well coming up in both the MRI and echo literature is a left atrial strain analysis. Because so many of the features of cardiac amyloid overlap with other conditions, the left atrium is an interesting way to help differentiate them, given that amyloid should affect that more than, say, hypertensive heart disease, given that it deposits in the left atrium as well as the right atrium. So in this study of 426 patients, 262 in a kind of consecutive series of screening at a tertiary center were diagnosed with cardiac amyloid. 117 had AL, 145 had transthyretin, and the rest had either normal or hypertensive heart disease. And atrial strain was compared between the 3 groups. And the ATTR amyloid had by far the most markedly abnormal strain, more so than AL amyloid groups, and less so than patients who did not have any hypertensive heart disease at all. So strain, left atrial strain was another thing that was quite predictive, and it was more abnormal in transthyretin compared to amyloid, AL amyloid. So going back to this case and kind of applying some of the kind of guidelines to how kind of he was managed and kind of why we ordered the echo for him. So this patient essentially from the CCS guidelines would fit some of the kind of indications for echocardiography and further workup for amyloid based on the fact that he had peripheral sensory motor neuropathies. He had bilateral carpal tunnel syndrome. And he also had orthostatic hypotension that was kind of unexplained by other features. He also had unexplained increased LV wall thickness, given that he did not have a significant history of hypertension. The CCS guideline for amyloid places a fairly important role on echo in terms of screening for amyloidosis, but not for the final diagnosis. If cardiac amyloid is suspected on any of those features that I had just pointed out, then imaging with either echo or CMR would be indicated. Very early on in the kind of assessment course, screening for a plasma cell dyscrasia is important to rule out AL amyloid. If AL amyloid is suspected, that takes you down a completely different pathway. If AL amyloid is ruled out on that basis and ATTR amyloid is suspected, the next step is essentially doing a technetium pyrophosphate scan, which is highly sensitive and specific for ATTR amyloid. And this is kind of the study using pyrophosphate scanning that showed that 13% of patients over the age of 60 with HFpEF were positive for ATTR using pyrophosphate. And this is what a positive scan might look like. So going back to this case, this was a more interesting case because this gentleman did go for genotyping, and he did test positive for a very common mutation, the PV142I mutation causing hereditary transthyretin amyloidosis. The patient was of African Caribbean / Jamaican ancestry, in which case 3.5% of patients from that lineage in North America do have this mutation. It is an autosomal dominant mutation, but the penetrance is quite variable, and people may present at different ages, or they may not present at all with any symptoms. This patient initially was managed with oral diuresis, but he could not tolerate any afterload reducing agents, and spironolactone, even dapagliflozin. He became quite hypotensive with that. That's fairly common in amyloid, that they can't tolerate their standard heart failure therapies that well. He was started on tafamidis, which is a transthyretin protein stabilizer, and this improved his symptoms from NYHA class 2 to 1 over a year and a half. But he did develop neuropathy symptoms, which are not effectively treated with tafamidis, and he was switched over to patisiran just a month ago, actually. So I'm not sure how he's doing with that, but there's some suggestion that this agent, which is an mRNA silencer for amyloid, might be more helpful in treating his symptoms. Kind of this is what I just mentioned about the, sorry, this should be ATTR. This is kind of the prevalence of hereditary transthyretin amyloid, 3.5% overall in African Americans in the US. And the mutated allele is found in over 10% of those patients over the age of 65 with heart failure. So it's a very significant thing. So I just wanted to kind of wrap up by going back to the objectives. So we reviewed the types of cardiac amyloid today, discussed that kind of wild type ATTR is the most common that we'll encounter clinically, but AL amyloid and H-ATTR are also significant. And this patient did end up having H-ATTR. We discussed kind of what features on echo should raise the suspicion of cardiac amyloid, like unexplained wall thickness and restrictive filling. And then we discussed kind of how we can more definitively differentiate cardiac amyloid from other infiltrative heart diseases on echo. There's a huge emphasis on strain analysis for that, particularly that GLS, reduced GLS with apical sparing pattern. And finally, some new things coming out in the echo world for this include the GLS-EF ratio, left atrial strain. Definitely has some research emerging in both MRI and echo worlds, as well as I think there's an emphasis on diagnosing this in the severe aortic stenosis population, as there's quite a large overlap in people going for TAVR, also having cardiac amyloid. So yeah, that's essentially all I had to say. If anyone has any questions or wants to discuss.
So thank you, Waseem, for such a comprehensive review of cardiac amyloid, and both in the echo side and also the clinical side. And we do recognize that Calgary is one of the capitals of the amyloid research, and we're very fortunate to have Dr. Noel Fine in Alberta, who heads the Canadian guideline for amyloid. So very, very good. Thank you. And there's a lot of interest actually in the speckle finding or speckling on the amyloid historically, because we used to use only harmonic imaging, but what happened is with the we used to use only something called fundamental imaging, and harmonic imaging came sometime in 2000, 1998, 7, somewhere around there, and then it makes everything kind of sparkling. So this classic, classic Starry Night pattern that was described in the old textbook, suddenly there are far more patients who have that. So in many ways, one strategy is to figure out to turn off the harmonic imaging and then go back to fundamental imaging and see if it still sparkles. So that's one of the options to do it. And some of the machines still have that options of going back from harmonic imaging, which is routinely being used right now, and to go back to fundamental imaging. So that's something worth thinking. The other thing that for our group at St. Mike's, I think one of the discussion we had in our last QA round is for any patients who have a wall thicker than 11 millimeters, so that means 12 or above, we should really think about doing the GLS on a regular basis, because it can help to identify patients or give additional clues to identifying patients with amyloid. So amyloid is one of these weird things that has a rekindled interest in history because of the discovery of new medications to treat it, such as tafamidis and others. And it's up to the clinicians and imagers, both in echo, MRIs, and nuclear these days, to actually try to find these patients, because you find earlier, they can improve their quality of life and lifespan. So that's why there's a rekindled interest on this in the last 4 or 5 years of, when you go to any echo meetings, you'll have like the sessions on thickened wall and, amyloid, Fabry's, and all of the above. So anyway, I'll let other people ask questions and comments, so please go ahead. Okay, if not, I'll start with the first question. So one of the interesting observations, apical sparing using GLS and with the cherry on top pattern. This is like very interesting observation. Have you come across Waseem, the reasoning or mechanism behind that?
I did come across one theory that had something to do with the kind of where the amyloid fibrils were deposited themselves.
Right.
And if they were actually in the reason why that pattern emerges.
That's something I come across as well. I wonder if it's been proven one way or the other, or just speculations. One other question, and just more thought-provoking. On a day-to-day basis, we see lots of patients with thickened wall, and sometimes we have a good explanation for it, sometimes we don't. And even with patients, because as they get older, there are lots of other things going on, like renal failure or hypertension that might cause thick wall as well. But on the other hand, once you start seeing thick wall, should we routinely start thinking about doing like nuclear scan on them, or versus MRI to go and find amyloid, or the other thought-provoking question is, should we screen every single one with low flow, low gradient AS?
Mm-hmm. That's really interesting. I was thinking about that as well, and I think the benefit would be that we probably would catch more cases of transthyretin amyloid for sure. Our echo, package for assessing it is not perfect. Strain analysis is very suggestive but not perfect. So I think if we broadened our diagnostic net, we would catch more patients for sure. But I think we also have to balance the cost of doing that on our system. That having lots more nuclear scans and MRIs would be a resource issue. And I think we also have to ask, are we able to treat it once we make that diagnosis? For now, I know that the criteria for getting things like tafamidis and the mRNA silencers is very onerous and quite limited. It also requires an endomyocardial biopsy. At least it did in Alberta. So I think
right.
If it comes to a case where that treatment access is more robust, then I think we could probably make a good argument for better screening with pyrophosphate scans. But I think in this kind of with this treatment paradigm we have, I wouldn't go that far yet.
Yeah, but we're in the era of the rare disease era, where a number of different companies have made very good therapeutic agents for rare diseases such as amyloid and Fabry's. Obviously, the people who have them relatively are not as many, but and yet to be discovered, because sometimes we miss the diagnosis or not frequently. And then the treatment is very expensive, and then you have to sort of counterbalance the quality of life improvement as well as the length of life that is extended. So I think those are all sort of questions that we have to ask at a society level.
Mm-hmm.
Any questions or comments from my other colleagues or participants? You can unmute
Bob.
if you like. Bob, hi. Good morning.
Hi. Question about hereditary amyloid. Should we be, if we find a patient that has a gene, should we be screening family members?
I think I haven't come across any guideline suggestion to kind of make a firm statement one way or the other. I think it comes down to patient preference. I think it's worth counseling other family members around that this is an autosomal dominant disease. There's a fairly high chance that if a proband has it, that their family members could have it, and counseling children on the possibility of also becoming symptomatic with this is important. But in terms of genetic screening, I have to think if that would change the management for those patients. And apart from just some surveillance and control of blood pressure and other modifiable risk factors, I can't immediately think of a benefit to kind of widespread screening. But I'm happy to look into kind of if there's any guidelines or more firm recommendations on that front and get back to you.
Any other questions or comments? So once again, I want to thank Waseem for giving such a great and comprehensive review. And it's one of these topics that you can hear over and over again. You always learn something new. And with that in mind, we're going to sign off, and then we'll see you next week.
Thanks, everyone.